Welcome to this MedUni lecture on medical causes of abdominal pain. In the previous lecture, we focused on surgical abdominal emergencies. In this lecture, we will look at important medical causes that can present with abdominal pain. The key message is this: not all abdominal pain is surgical, but medical causes can still be serious and time-critical. As always, assess the patient first, not just the abdomen. Abdominal pain is a very common presentation in the emergency department, wards, clinics, and primary care. Many cases are gastrointestinal, such as gastroenteritis, gastritis, hepatitis, or inflammatory bowel disease. But abdominal pain can also come from outside the abdomen. Myocardial infarction, pneumonia, DKA, sepsis, and metabolic disturbance can all present with abdominal discomfort. So do not only ask, is this surgical? Also ask, could this be a serious medical illness presenting as abdominal pain? By the end of this lecture, you should be able to recognize common medical causes of abdominal pain, identify red flags, and use a structured approach. We will focus on A, B, C, D, E assessment, targeted history, bedside tests, blood tests, and appropriate imaging. The aim is not to memorize every rare diagnosis. The aim is to recognize important patterns, avoid dangerous misses, and escalate early when needed. If the patient looks unwell, start with A, B, C, D, E. Not just the abdomen. Check airway and breathing. Pneumonia, PE, or metabolic acidosis can cause abdominal symptoms. Assess circulation. Tachycardia, hypotension, poor perfusion, or raised lactate may indicate sepsis, DKA, shock, or bleeding. Check disability. Glucose, confusion, drowsiness, reduced consciousness. Examine fully. Temperature, hydration, rash, systemic signs. If unstable, monitor, gain IV access, resuscitate, give analgesia, and call senior help early. Use Socrates. Site, onset, character, radiation, associated symptoms, timing, exacerbating factors, severity. Then ask targeted questions. Vomiting/diarrhoea, gastroenteritis, DKA, adrenal crisis, sepsis, bowel inflammation. Epigastric pain, gastritis, pancreatitis, ACS, DKA, biliary disease. Jaundice, liver, biliary, or hemolytic causes. Urinary symptoms, UTI, pyelonephritis, renal colic. Always ask diabetes, alcohol, medications, anticoagulants, immunosuppression, travel, pregnancy, past history. This slide highlights red flags. Look for shock or sepsis, confusion, persistent vomiting, severe dehydration, worsening pain, fever or hypothermia, GI bleeding, jaundice with fever, raised lactate, metabolic acidosis, abnormal ECG, chest symptoms, or pregnancy possibility. These features should make you pause. Do not label the patient as simple gastroenteritis if they look unwell. Red flags mean reassess, investigate, and escalate early. What to investigate? Think in 3 layers: bloods, bedside, and imaging. Bloods: FBC, CRP, UND, LFTs, glucose, amylase and lipase, VBG and ABG, lactate, plus coagulation if needed. Bedside: OBS, urine dip, pregnancy test, if relevant, capillary glucose, ketones, ECG. Imaging: guided by suspicion. Ultrasound to biliary, renal, pelvic, free fluid. CT, abdomen and pelvis with contrast leads to serious or unclear pain. Chest X-ray leads to pneumonia or free air. Remember, investigate wisely, but never delay treatment in an unstable patient. Gastroenteritis, the common culprit. Think vomiting, diarrhoea, crampy pain, plus or minus low-grade fever. Most are stable and bounce back with fluids, plus or minus antiemetics, plus safety netting. But don't be fooled. Diarrhoea can mask serious pathology. Appendicitis, 1B, D, ischemia, obstruction, sepsis. Red flags: reassess and escalate if you see localized pain, guarding, shock, blood in stool, severe dehydration, persistent vomiting, high fever, or a toxic-looking patient. Hepatitis and liver pain. What to spot? Think right upper quadrant discomfort, nausea, fatigue, anorexia, fever, dark urine, pale stool, or jaundice. What's causing it? Viral, alcohol, drugs, autoimmune, or biliary obstruction. Key tests: LFTs, bilirubin, INR and coagulation, glucose, viral screen, and ultrasound if obstruction is suspected. Red flags: escalate now if you see confusion, bleeding, very high INR, hypoglycaemia, severe jaundice, sepsis, or signs of acute liver failure. These patients need urgent senior review. Don't wait. Inflammatory bowel disease. Crohn's versus ulcerative colitis. Think abdominal pain, diarrhoea, blood in stool, weight loss, fever, fatigue. Crohn's. Any part of the gastrointestinal tract. Look for right iliac fossa pain, strictures, fistulae, or abscesses. Ulcerative colitis. Colon only. Think bloody diarrhoea and urgency. Red flags. Don't ignore. Severe bloody diarrhoea, fever, tachycardia, dehydration, anemia, toxic megacolon or peritonism. Severe colitis can deteriorate fast. Act early. DKA, the great mimic. DKA can be mistaken for a surgical abdominal emergency. Abdominal pain, nausea, vomiting, dehydration, drowsiness, rapid breathing. It can even mimic a surgical abdomen. Think DKA if you see diabetes, known or new, vomiting, abdominal pain, ketones, dehydration, or altered mental state. Key tests: capillary glucose, blood ketones, VBG/ABG, bicarbonate, pH, potassium, renal function, and infection screen. Treatment: IV fluids, fixed-rate insulin, potassium replacement, dextrose when needed, and treat the trigger. Remember, abdominal pain plus vomiting plus ketones equals think DKA early. HHS, the other hyperglycemic emergency. Think older patient, type 2 diabetes. Presentation: severe dehydration, very high glucose, confusion, weakness, plus or minus abdominal discomfort. Key difference from DKA: less ketosis and acidosis, but more severe dehydration and osmolality. High risk. Management: careful IV fluids, monitor electrolytes and osmolality, prevent thrombosis, involve seniors, and avoid rapid correction. Slow and steady wins this race. Hypoglycaemia. Think fast. Sweating, tremor, hunger, anxiety, confusion, collapse, seizure, or reduced consciousness, plus or minus nausea or abdominal discomfort. Who's at risk? Diabetics, insulin or sulfonylurea users, elderly, septic, confused or drowsy patients. Check bedside glucose early in anyone unwell. Treatment: conscious and safe to swallow, fast-acting oral carbohydrate. Not safe, intravenous glucose or glucagon as per local hospital protocol. After treatment, find the cause and prevent recurrence. Urinary tract infection and pyelonephritis don't underestimate. Urinary tract infection: suprapubic pain, dysuria, frequency, urgency, fever or confusion in older adults. Pyelonephritis: flank pain, fever, rigors, vomiting, systemic upset. It's a step up. Tests: urine dip plus culture, pregnancy test if relevant, bloods, renal function, and lactate if unwell. Red flags: escalate. Sepsis, hypotension, persistent vomiting, pregnancy, immunosuppression, obstruction, renal impairment, or suspected infected stone. Infected obstructed kidney equals emergency. Call urology now. Acute coronary syndrome can be mistaken for a gastritis. Think epigastric pain, nausea, vomiting, sweating, breathlessness, collapse, or fatigue. High-risk groups: older adults, women, and diabetics. Don't miss it. If epigastric pain plus cardiovascular risk factors leads to think acute coronary syndrome, action: ECG early. Repeat if symptoms persist. Check troponins per protocol. Remember, a normal first ECG does not exclude acute coronary syndrome if the story fits. Renal and ureteric colic. Severe colicky pain with restlessness. Sudden severe flank pain radiating to the groin. Patients are restless, nauseated, vomiting. They just can't get comfortable. Plus or minus hematuria. Initial steps: analgesia, antiemetics, hydration if dehydrated, urine dip, renal function, and imaging per local protocol. Red flags: escalate, fever, sepsis, solitary kidney, AKI, bilateral obstruction, pregnancy, uncontrolled pain, or persistent vomiting. Fever plus renal colic? Think infected obstruction. That's an emergency. Medications, the hidden culprit. Always take a medication history. It could be the answer. Common offenders. Non-steroidal anti-inflammatory drugs leads to gastritis, ulcers, bleeding. Antibiotics leads to diarrhoea, including C. difficile. Opioids leads to constipation or ileus. Anticoagulants lead to bleeding risk. Steroids lead to mask peritonitis or increase ulcer risk. SGLT2 inhibitors lead to euglycemic. DKA. Always ask about recent antibiotics, NSAIDs, anticoagulants, diabetic meds, alcohol, and recreational substances. Key learning points. Take-home messages. Medical abdominal pain can be GI, metabolic, infective, renal, cardiac, respiratory, or drug-related. Unwell patient? Start with ABCDE. Always. Don't label severe pain as gastroenteritis without checking red flags. Do bedside tests early. Glucose, ketones, urine dip, pregnancy test, if relevant, ECG, lactate, and basic bloods. Remember the mimics: diabetic ketoacidosis, acute coronary syndrome, pneumonia, sepsis, pyelonephritis, renal colic, hepatitis, inflammatory bowel disease. Final rule: treat the patient, reassess regularly, and escalate early if unstable. Exam traps. Don't get caught out. Trap 1. Assuming it's surgical. Not all abdominal pain comes from the abdomen. Think DKA, ACS, pneumonia, pyelonephritis, hepatitis, porphyria. Think broad. Trap 2. Missing cardiac pain. Epigastric or upper abdominal pain equals possible ACS, especially in older adults, diabetics, and women. Do ECG early. Consider troponin. Trap 3. Reassured by diarrhoea. Diarrhoea not equal to always gastroenteritis. Consider mesenteric ischemia, sepsis, appendicitis. Look at the whole picture. Trap 4. Forgetting DKA. DKA can mimic a surgical abdomen. Pain, vomiting, dehydration, fast breathing. Check glucose, ketones, VBG/ABG early. Trap 5. Skipping a pregnancy test. In any woman of childbearing age, exclude ectopic pregnancy. Simple test, but missing it is dangerous. Trap 6. Trusting normal early observations. Elderly, immunosuppressed, or early septic patients may look well initially. Normal obs not equal to safe. Reassess. Key message: think beyond the abdomen. Rule out medical mimics and never delay treatment in an unstable patient. Pause the video here. Try these questions before moving on. Check your answers in the attached free downloadable document. Good luck! Test yourself first. Thanks for watching this MedUni lecture on common abdominal medical emergencies. Key takeaway: abdominal pain isn't always surgical, but medical causes can be just as dangerous. At MedUni, we make clinical learning simple, practical, and exam-focused. Don't forget, download the attached notes and high-yield MCQs to test your understanding and deepen your learning. See you in the next session. Keep learning, keep saving lives.